Welcome to another month of the Tea and Toast Club, a geriatric mini-series hosted by the Generalist. This month, we're talking all things long-term care. If you're interested in hosting, please connect with us. We'd love to have you join the conversation about older adults. I'm Dr. Christine Miller, Care of the Elderly Doc, joined today by another Care of the Elderly physician, Dr. Margaret Manville, who is a long-term care mover and shaker on Vancouver Island. Let's get things started for today. Can you tell us about your geriatric background?
Prior to my graduation, I was a fourth year intern, and I was intimidated by the long list of medical maladies and medications that older patients would come in to the hospital with. And so I thought I needed more education around geriatrics. So I did a month on the geriatric unit at St. Paul's Hospital, and was kind of impressed with the thoroughness that they approached their practice, and also how much I needed to learn about dementia diagnoses. For example, I remember doing a mini mental status exam on a woman who was really baffled as to why she was there, and she wanted to go home, and I thought, why are they keeping her there? And she seems nice and she could tell me all this stuff about her family. And then I went to do the Folstein, and I think her Folstein was like 18 or something like that, and I thought, that's not good. How come I can't just tell that she has dementia and is probably needing to be here? It was a good lesson for me to recognize how much I needed to learn. And it's just kind of fascinated me that I was totally duped by this woman. I was very interested in it, like through my residency program. And my husband and I, after graduation, we went to Northern Ontario and did remote medicine in a small town. 4 of us from UBC were the 4 doctors in a 5-doctor town. So that was really fun and amazing. And I got to do some of the medical director work at the local long-term care facility. But I hadn't really, I think I'd set foot in one long-term care facility before, I went to Northern Ontario. I think in residency, I just went with my preceptor to one site and that was it. But I also remember enjoying it. I just remember thinking, this is a nice environment and my resident has what she needs here. And I'm providing some medical service for her in her home. It just seemed really, really special. So I enjoyed my work in Northern Ontario, and I thought, my elderly patients, I still don't have a lot of comfort with understanding how to prioritize their needs and what my goals are and what their goals are. So I applied for a fellowship in care of the elderly, a year fellowship at the University of Ottawa, and I got it. And so my husband and I, he was also doing an emerge year, we went and lived there for a year, and I did my care of the elderly training, which I really enjoyed because it was after I'd been working already and I had lots of questions. And so that made it, I think I just really, really enjoyed that because I had some practice experience, and then I was sort of coming back into a very academic center, and that was very fun. And then the plan for us was to move to Comox, practice there for a few years, and we ended up staying for 12. So I had a full family practice, and then I started doing long-term care medical coordinator work at the 2 long-term care homes there. And after we had kids, I guess I did locums. And I also started with another colleague, a geriatric medical arm of our seniors outreach program. We had a geriatric psychiatry arm, but we didn't have a geriatric medicine arm. So our geriatric psychiatrists were assessing for falls, for example, or polypharmacy, or things that are very much in the medical side of that practice. So we started that program. And I also was involved with a project in our hospital on ALC residents. The plan was to cohort them on a unit because they were all over the hospital and not well looked after, unfortunately, because acute care nurses need to look after acute care patients, and they don't have the skill set that some of our long-term care nurses do, or nurses that are used to more chronic care. And the staffing, again, was not great for a resident whose most important thing was maybe to get to the bathroom and get up and mobilized and have some stimulation in the day, and then have a look at their medications prior to discharge to home or to long-term care. And that was a project I did through UBC, through the Clinical Scholar Program. It's an R3 program. And we ended up publishing our paper because the results were really excellent. It showed that we made a huge difference in the lives of these patients. They got home more, they were transferred to long-term care in better condition, we decreased medications, we decreased antipsychotics, all of the good things that you really want to do for your elder patients. And we published it in the Canadian Family Physician, and we won a prize that year for the best original research project. So that was sort of the first 12 years of my practice, and then, or 12, 15 years, I should say. And then we moved to Victoria. And so I started locuming, and I also started working in long-term care. And I took on some administrative roles. And then just before the pandemic, my mentor, actually, who had done the long-term care director work for 18 years, Dr. Tom Bailey, had unfortunately suddenly passed away in October 2019. And because I was the geography for sort of Victoria South Island lead, they approached me to apply for the job, and I got it. So I started mid-January 2020 as the medical director of long-term care for the island, thinking, well, this is a 2-day-a-week job, it's going to be just fine. And then we all know what happened in March, and it became a full-time job. Like everything else went to the wayside. Full-time, on weekends job for about 3 months. So it was like trial by fire, and I really didn't know. I don't know how long-term care ran before the pandemic, because my wonderful mentor had passed away, and I didn't have anybody to sort of show me the ropes, and then COVID hit. So it's been a total trial by fire. But it's been, I would say that work has probably been the most satisfying of my career, is to be on the real front line of trying to manage a pandemic in a resource-poor environment like long-term care. And our admin team in Island Health did an amazing job. We didn't have a case of COVID in long-term care on the island until November 2020.
Wow, 9 months into the pandemic before you had your first case of COVID in long-term care on Vancouver Island. I think that really is a testament to the great teamwork that you had mentioned earlier. If we think about long-term care from a top-down level, can we start off by discussing the long-term care initiative that you're involved with?
The long-term care initiative is administered through our divisions of family practice all over the province, and they incentivized looking after long-term care residents by attaching some funds to 5 best practices. So the 5 best practices are care conference attendance, meaningful medication review, 24/7 coverage, so after hours coverage also, completed paperwork, so things like a MOST and other documentation, and proactive visiting. So the long-term care initiative is available to all physicians and divisions. And in Victoria, we've had a couple of excellent outcomes from the funding. We looked at our homes and wanted to decrease the number of physicians who had 1 or 2 patients, because evidence shows, and we've seen, that if you only have 1 patient at a residence, the chances of you going physically to go and see that resident if there's an issue is pretty low. Often that gets dealt with by a phone call, and before you know it, you haven't seen that resident for 9 months, and maybe they really need to see you. The efficiency of that for the staff is poor as well, because you could have 80 residents in a home and you could have 50 physicians, and it's very inefficient for the nurses. It takes a lot of time to track physicians down, as we know sometimes, faxing and phone calls, etc. So what we did was try to cluster the number of residents per home with a fewer number of physicians. So for example, I go to 2 homes at the moment. I have 24 to 26 residents per home. I go there every week, actually. I usually have a new admission. I usually have a care conference or a medication review, and then I usually have a palliative patient. So I feel like I'm very busy actually on those days. And sometimes my colleagues who are in other sites say, well, how can you spend that much time at a long-term care residence? I find when you have enough residents at a site, there's always something to do. You can always look at their medications and try to reduce their antipsychotic use, for example, talking to families, phoning them and updating about their loved one, addressing the most. There's lots that you can do.
That makes a lot of sense, having dedicated physicians for facilities rather than piecemealing in and out. Any other projects you've got on the go currently?
So that's what I like about this role, is like I can do more for more residents, because we have about 6,000 residents on Vancouver Island in long-term care. Right now, we're really trying to address the younger population in long-term care that have acute psychiatric mental health needs and addiction needs. We've always had younger residents in long-term care because the cutoff is age 19. Anybody 19 or older who requires a long-term care facility, if they qualify, they will be able to come into one of our facilities. But the proportion of residents under 65 is going up. Sorry, under 75, both. But they're both going up. And a lot of it has to do with the homelessness crisis, with the toxic drug supply, people with brain injury. And don't typically fit well with the frail elderly. So we had planned a unit at the Summit, which is a brand new long-term care facility with 325 beds, to address the needs of younger residents who need different programming and don't want to play bingo all day long and maybe living with us for a much longer period of time. And that's what it sort of started out being. And it really is a site where people are actively using drugs. We have to address safe supply in that unit. We have increased the staffing on that unit to reflect the population, and it's just the start. So today I was supposed to have a meeting about how do we engage our addictions teams, our adult mental health teams to support these residents, not just at the Summit, but up and down the island, because we've even had people, moving from their homes on the North Island to come and live in the Summit because they don't quote unquote qualify in any other long-term care facility, because other long-term care facilities can refuse to take those types of patients, and they do.
Yes, I've been to a similar unit where it's focused on younger patients, and there is a different feel to it. People are busy doing things, there's lots of coming and goings, and it's not the typical unit where you think about older patients sitting around in the TV room or at tables in the dining room. Here's a question for you. Any thoughts on antipsychotic use in long-term care? Hot topic these days.
The other thing we're really working on in Island Health is reducing the potential inappropriate use of antipsychotics. So we call it the AUA program, or appropriate use of antipsychotics. And most recently, we've called it sort of reimagining long-term care. Because nobody I know as a nurse or a healthcare aide or physician, gets up in the morning and says, I want to reduce antipsychotics. They're like, I want to improve the quality of care for my patients, for my residents. So that's kind of how we're approaching it. And there's lots of great work that's being done here. I get pulled into, things for the government, which is really interesting. We're working on an antipsychotic policy, really interesting work where we're trying to set benchmarks for long-term care homes on their potentially inappropriate use of antipsychotic rates, because they've gone up since the pandemic. And we know we can do better, but there's lots of reasons why it's gone up. So really, supporting homes to try to address that issue.
It sounds like lots of work is being done at an organizational level for antipsychotic deprescribing. How should I approach this practically on my next long-term care shift?
If I have a resident who is on an antipsychotic, I sort of think about, on admission, are they on an antipsychotic? Why are they on that antipsychotic? Was it an antipsychotic hangover from their delirium in hospital, for example? So if I know that that's the case, because I've read the notes, then I will start tapering them right away. I don't go 50% at once, for example. So I don't really think about it as percentages. I sort of think about it, how many times a day, what is the dose, and then how do I manage this over a few weeks, basically. And that, again, that's why it's nice to go regularly, because then you can actually know sooner than later whether it's working or not. And then it gives you some confidence to keep going. And then the staff know that you have their back. You're there and they can talk to you about it. If it is a severe agitation, hallucinations and delusions, I'm going to pause that. It's a little bit different. But for those types of behavioral reasons for going on an antipsychotic, 3 months, that's fine to sort of review. And I try to review after 3 months. What I often do is ask the nurses to do some behavioral mapping. It's color coded, and the care aides can, by the hour, sort of track whether there's behaviors or not. And so at a glance, it's quite helpful. Sometimes you can tell on some of the charting that there's an issue, but it's way more powerful to have more data points than just one note in the chart. And then the other thing is, really have a hard time prescribing anything for personal care. I mean, how would you like it if somebody you didn't know came up to you and wanted to pull your pants down, for example, right? And take off your clothes. That's very, very intimate and very difficult for any of us. An approach is the thing that usually makes the biggest difference. I don't want anybody to be injured. If there's an at-risk behavior, I need to know about that. If they're resistant to care, we need to work with the staff and really understand what other non-pharmacological approaches can be used instead of a medication, because the medications are very, very much a placebo also for our staff and sometimes for our families, but often, we can get away without doing that with a really good care plan.
Some good thoughts around antipsychotic tapering at the physician level. Some health authorities in provinces have found that programming also helps with managing behaviors. Montreal, for example, has mobile BPSD teams which help caregivers at home in hospital or in long-term care homes to manage BPSD symptoms of dementia through interpersonal, environmental, and behavioral approaches. Are you aware of any similar work being done in BC?
With our work in reducing antipsychotics, so appropriate use of antipsychotics, one of the projects we have is called the Care Coach program. But PIECES, so the PIECES training has typically been for nurses. The people who provide 80% of the care in long-term care are care aides. And with limited training, it's very hard to understand what these behaviors mean and what your responsibilities are around trying to manage that first before asking for a sedative. The PIECES training sometimes has not transferred down from the nurses to the healthcare aides who are dealing frontline with the behaviors that are associated with personal care, for example, which is really challenging sometimes. Our team, with our project for reducing antipsychotics, has devised something called the Care Coach program, which is a peer-to-peer healthcare aide who's specifically trained in, they have a few things that a few courses that they've done sort of enhance their training in PIECES and in gentle approach, and they mentor care aides. So they're supernumerary. And we got some national funding, I think, to do that in our homes. I can't remember how many homes participated. It's between 8 and 16 or something like that, but quite a few. And the results have been amazing. And some of the stories that we've had have been incredible. Like there was a resident at the Gorge Hospital who wouldn't come out of her room and was very irritable and angry. They just couldn't figure it out. And the care coach they have more time. So they're one of our behavioral team, really. And so they spent some time with this woman and realized that she was a piano teacher. And so they got her teaching piano out in the main area. And wow, what a difference. This woman now comes out of her room. She teaches the staff and the residents. Her quality of life has improved incredibly because this care coach had the time to spend to understand why. What would bring this person joy and comfort. That's just one story. I mean, there's so many stories, but the peer-to-peer is really important. I sort of feel like we should have behavioral teams embedded in each home that have this oversight and expertise around how to support each other to not use medications.
What a great story. I love the idea of figuring out that this lady only wanted to play piano, and that made a difference in managing her behaviors at the home without having to resort to medications. Any last thoughts you'd like to share with us today?
Don't be afraid to deprescribe. That would be one of the biggest improvements you could make for your resident, is to truly align their goals of care with the medication list. And even then, if their goals are, I want to live as long as I can, doc, and I'm 99 years old, they have a 50% chance of dying every year after 100. So realistically, the aspirin and the statin, all the preventative medications in the world isn't going to change that for that resident. So being very mindful about time to benefit, numbers needed to treat, and goals of care for all of the medications that are preventative medications. Most of the time, you can get away with deprescribing. I feel like I have more courage now than I did when I was a new grad to really look at the medication list, because I've seen and you've seen this too, this patient should be on Coumadin or a DOAC for the rest of their life. Nobody imagined what the last chapter of their life might be in a long-term care facility, where having a stroke or a heart attack would not be the worst thing that would happen. It may actually be a relief of suffering. So I would really encourage people to understand the role of medications at the end of life, really, and how much good you can do by decreasing the medications to only what is needed for comfort and less worrying about things that are preventative in nature.
And that wraps up another episode of the Tea and Toast Club. If this episode was helpful, feel free to pass it on to your colleagues. As always, all our opinions are our own and do not represent any affiliated organizations or institutions.